Okay, why is this important to me? Why should I, as a practicing CRNA who has all this technology at my disposal, have electronic record, which is taking all of my vital signs, all of my respirations, putting it into my chart. I have so much going on. Why should I use a relic? Why should I resurrect this relic? I like to think of that saying, those who cannot remember the past are condemned to repeat it. Remember, before we had all this technology, as anesthetists, we were right there. We were in contact with our patients. We could feel their pulse. We could hear their respirations. We could see their color of their skin. We knew what was going on with our patient. As a profession, we've even used that motto to tell the world, every breath, every beat, every second, we are there. We are there. Your precordial stethoscope will have you attached to your patient, and every breath, every beat, and every second, you will be there to best assess your patient. Does this look familiar? Is this what you're seeing every day as you go to work, in your work environment? And ask yourself, are you there for your patient every breath, every beat, and every second? Your monitors are all there, high tech, showing you everything. But what is your patient telling you? Besides the latter signs of the vital signs, what are they telling you right now? Can you tell? This is your everyday operating room. All kinds of noise inside the environment. You have x-ray, you may have a surgeon talking, you may have opening up supplies, you hear the monitors going, but can you hear your patient breathing? Are you attuned to their every breath that they're taking? As a modern day CRNA, is this old analog stethoscope still worthy? Does it still have a usefulness in the operating room environment? How can a simple rubber tube connected to your ear be any worth to the modern day CRNA? As they always say, a picture can paint 1,000 words. As the CRNA, you can hear instant changes in your patient's respiration. You can hear the wheezes. You can hear all of a sudden decreased breath sounds. You can hear their cardiac status without having to rely on electronic devices. You can hear an irregular heartbeat. You can hear a muffled breath sound coming. The pulse oximeter, it equals oxygenation, but it's not telling you what your quality of your ventilation is. Auscultation is the only way that you can tell the quality of your ventilation. It's the only way you can early diagnose, treat any hypoventilation or even an endobronchial intubation. And welcome to the modern day operating room. This is exactly what most of us do. And we think we are doing situational awareness. We're being attentive. We're not reading a book. We're watching our monitor. We're looking at the bellows going up and down. We're looking at our EKG. We're looking at technology to assess our patient. But what are your electronic devices not telling you? What's the color of your patient's skin? Are the pressure points there? Are there any potential injuries? Is the patient all of a sudden developing some kind of increase in airway resistance that your monitors aren't showing you yet, but if you had a precordial stethoscope and you were listening, you could hear right away? of the common reasons we hear newer people to the profession say they don't use a precordial, that it's a relic, is that we have all of these monitors which increase our situational awareness. They make us safer. But here's a question for you. By not using it, is there a potential legal liability? The AANA, in a study in 2009, 59 of the 62 programs require the use of a precordial stethoscope. Even in the AANA standard for documentation of anesthesia care, practice and policy considerations, it says consider a precordial stethoscope, which means today, the modern CRNA, it is one of those things that in the legal system is saying that you need to consider this device. So if you have a complication because of hypoventilation that led to different kind of problems, who knows what the legal system is going to do, because it is listed that this is something that you need to do. The ASA, even the ASA, Standard 3 states that under the quality of ventilation, it says every patient receiving general anesthesia shall have the adequacy of ventilation continuously evaluated. We know ventilation is not oxygenation. Again, is there potential legal liability if we don't use it? Because there is a standard that you must continuously monitor ventilation. It is interpretation, it is a standard, and every legal system will interpret it its own way. But if you have a problem with a hypoventilation that led to problems, this could be something that could be pulled out to use against the practicing anesthesia person. Another potential for legal liability is, whether we should use it clinically or not, is that current publications of anesthesia textbooks, whether they're edited by the CRNAs or edited by the MDAs, they all cite that the importance of the precordial stethoscope. They all cite that the precordial stethoscope should still be used, especially in the pediatric population, and they make a reference in their citation, even though modern day practitioners are not using it, it is a tool that should be used. So therefore, it's a potential that either we need to change our textbooks or we need to realize that we should continue to use this and not just rely on technology. As far as a legal that's on the books, that's actually been held, here's a situation where there was a hypoventilation, there was a poor outcome. The patient sued the CRNA, the patient sued the MDA and the hospital. What happened in this situation is the CRNA was thrown out at this time in 1985, which still occurs today in any states that do not have full practice authority, but the CRNA is considered a nurse, and nurses cannot make a diagnosis. So therefore are not, if there's hypoventilation and the use of a stethoscope to make a diagnosis, they were not held responsible. In this situation, even in this case, the anesthesiologist was also taken off the case or the lawsuit by the court system, but the court system did find Lansing General Hospital liable, but they found them liable because the hospital was negligent for not requiring a CRNA to use a precordial stethoscope. Thus far, I have not found if this statute has been overturned. I just wanted to present that so you are aware that that is out there. And this was published in the ANA Journal in 2002. It's a closed claim project that was published. It was a cooperative project with the Australian Incident Monitoring Study, and it looked at all these closed claim events, and it came down with telling the lessons learned and what their advice was based on these different closed claim accounts. And basically it said this: autonomic, non-invasive blood pressure monitoring frequently detected incidents latent in their evolution, and that a precordial or a traditional stethoscope should be available at all times to augment other monitoring approaches. As we said in the beginning of this module, basically 1991 is when technology, EKG, pulse oximeter, and total CO2 monitoring all came standard monitors. Yet here, over 10, 11 years later, anesthesia is still being held accountable, and it's still saying that in the legal system that if you do not use that, there are cases in where anesthesia is held accountable. So you want to consider that. As far as the legalities of it and doing the best for your patient, here's the take-home message. Here's the take-home message from that study. Respiratory adverse outcomes are the largest class of injury. It says care was judged substandard 76% of the time. And when there was death or brain damage, 85% was respiratory cases. And of those 85% of the cases, 72 were deemed preventable. And I would say that when you use a precordial stethoscope, especially in the pediatric population, you're right next to the patient. You pick up on things much quicker. I have heard some people say they don't want to use a precordial stethoscope because they can't hear what else is going on in the room. My answer to that is, well, yes, I want to hear what the surgeon's saying, but the one thing I want to hear is I want to hear what my patient is saying. I have one ear to my monitors, I have one ear to my patient. And the surgeon, if they really need me for something, I'm attuned to them, but they can get my attention elsewhere versus me listening to the rest of the conversation in the room, which could distract. Okay, in conclusion, here's a scenario for you to kind of bring it all together. You are the relief CRNA. Your patient's a 1-month-old, 4-kilogram term infant for exploratory laparotomy. Here is your patient. What potential concerns do you have as you come into the room to take over for this case from the other CRNA? What could possibly go wrong with this case based on what you're seeing right now? Let's see. The surgical drape is pushing down on the endotracheal tube, which could be an endobronchial intubation inadvertently knowing. Remember, these are small patients, so the drape's pushing down, the surgeon's arm's right there, there's suction equipment, there's instruments, and they have a tendency to throw their instruments at the head of the bed for some reason. Also, because it's a small child and it's a gastric procedure or a bowel procedure, there's a possible gastric extension. If there's gastric distension, then the little baby's stomach's going to inflate. When it inflates, it pushes up on the lungs, and it could do a couple of things. It could cause decrease in being able to ventilate well, which all of a sudden there's some restriction in the chest, which your precordial stethoscope would pick up on. You could have a displacement of the endotracheal tube, which again your precordial stethoscope would pick up on. Also, when we think that, oh, we're going to rely on our pulse oximeter, with the pediatric population, especially the smaller one, you have those big halogen lights that are beaming down, and the patient's a small area, so all these lights are in a small area. That halogen light has a tendency to interfere with the pulse oximeter based on the light interference, and you could have a great waveform, but your SAT reading 78. Now, is your SAT reading 78 the light interfering with your pulse oximeter reading, or is it the actual patient having difficulty? Again, if you have the precordial stethoscope in your ear, when you hear that pulse oximeter going down, you can say, I've got good breath sounds, I'm doing good, it might be my pulse oximeter, let me relocate my pulse oximeter because I know that I'm ventilating. For some reason, my monitors say I'm not oxygenating. Let me see if it's a technical error or if it's actually the patient. And the other problem is visibility. We're not going to be able to see. Everything is coming down on us, and trying to move their hands while we're trying to explore tends to get people a little upset that we're pushing their hands out of our field trying to assess things, and everyone stops and then everyone's in your business type of thing, versus like if you had a precordial stethoscope in your ear, you could say, I got good breath sounds, I'm going to do this, I'm going to check what's going on, I'm going to check my pulse oximeter, I'm going to see if my stomach is inflating. You could check all that without anyone else getting involved. If this was your loved one, what is that one monitor that you would hope that pediatric CRNA would be using at all times to know that they were taking the best care of your baby? Remember, every breath, every beat, every second, the CRNA is there. Your precordial stethoscope is there for every breath, every beat, every second, and therefore you are there for your patient.